243 research papers, 300 acres campus, 100 plus faculty and staff, 106 students, 1,000 plus delegates, 4,320 minutes. This can only happen in SYMHEALTH 2017. I, Tarveen Kaur, student of MBA Hospital and Healthcare Management from Symbiosis Institute of Health Sciences, on behalf of Symbiosis International University, welcome each one of you to this session on health economics and financing. Health economics and financing is concerned with how financial resources are generated, allocated, and used in health systems. It also plays an important role in framing health policies and key elements of planning and evaluation process. Sound financial planning is essential to strengthening health systems and contributes directly in improving the impact of healthcare intervention. Let's know more about health economics and financing from our accomplished Professor Jyoti Chandi Ramani. Ma'am, I request you to kindly grace the dais. Professor Jyoti Chandi Ramani has specializations in microeconomics, macroeconomics, managerial economics, and international economics. She has completed her PhD on foreign direct investment and corporate response and has more than 25 years of experience in teaching. She is director at Symbiosis School of Economics and has conducted management development programs for many well-known companies. Besides,
Thank you so much, Tarveen. Good morning, everyone. We've already cut into 15 minutes of our talk, of our session. So I thought let's go away with all these formalities. As the host institution, it's a very, great pleasure for me to welcome all of you this morning, our resource persons and our participants and delegates and colleagues, to this very wonderful conference that has been organized. And therefore, I, on behalf of Symbiosis International University, Faculty of Health and Biomedical Sciences, Faculty of Humanities and Social Sciences, extend a warm welcome to all. At the outset, let me tell my expert friends, I'm not a health economist. So I'm not accomplished in your area. I'm a student of yours at this point. I anchor this session with humility and with great learning. SYMHEALTH 2017, an international interdisciplinary conference on the theme healthcare in a globalizing world, enriching healthcare delivery through an interdisciplinary approach. I think we were just in the plenary session the next door, and there was a lot of emphasis on interdisciplinary framework. And I look forward over here with all these wonderful resource persons who've come, my colleague TP Singh from the engineering institution, and us, to see how we can take this forward, and of course, Amita from healthcare. Thank you for all of you for being here. Whilst conceptualizing the planning of this track and its sub-theme, we were keen that the session addresses some very pertinent questions to our varied participants. And the participants today include healthcare practitioners from across the country, industry professionals, research scholars, academicians, government officials, CSOs, NGOs, our alumni, our own faculty, and our own student. The sub-theme across the track include healthcare financing, global and national perspectives, from MDGs to SDGs, roadmap and policy direction, financing of SDG 3 especially. And over here, I'd like to tell you, my dear colleagues and friends and participants, that just around the 15th, 16th, and 17th of February, we had an international conference from the Faculty of Humanities and Social Sciences on select SDG goals. And we did not touch upon healthcare because we knew we were going to touch upon it here. 17 goals, it's daunting to touch so many. And I'm happy that this particular one conference, in some way or the other, through its varied tracks, will be touching upon, the goals pertaining to health. Over here, we are also going to talk about access to medicine, meeting the challenges, which would throw light on the drug pricing policy and the kind of regulatory framework required for the health sector. The government policies and interventions, and of course, the role of civil society and their network of support to the cause of improved healthcare delivery. As a part of social sciences, I've always been very proud of saying, okay, economics is the mother of social sciences. Typically, what we would talk about in our first class on economics when we would get in. And then I came across the words of Rudolf Virchow, a German pathologist, a public health activist, and a politician who stated in 1849 that medicine is a social science. And those words have just been talked about in the earlier class, so I'm not going to talk more about it. Our very eminent personalities who've come to share, to share their thoughts and their research work and their engagements in the sector. Dr. Srinath Reddy, the chairperson of Track 1, I was reading about him and he talks about how, and I quote him, a healthy nation is necessary for economic development, with India being behind her peers in South Asia and the BRICS, and emerging markets. Obviously, we need to look into this particular sector. He talks of, again I quote, intrinsic value of health apart from instrumental value, and that health is a right. To us economists, health is a merit good, providing benefits not only to self but others as well. The poll by Gallup International 2000, which was surveyed in 60 countries, and one of the key findings placed good health as the most important thing in life and topped the list with 44% of the respondents. Moving ahead, Dr. Geeta Sen, an eminent health economist, states, empowerment of people comes from the freedom they enjoy, and this includes, among others, freedom from poverty, hunger, and malnutrition, and freedom to work and lead a healthy life. This is, I quote, 1999. Ma'am, I won't be surprised when they were putting through the SDG goals, they probably read these lines, of yours, okay? Her views on gender gap, I quote, in India, we have traditionally failed in making and implementing human development policies for girls and women, be it in healthcare or education. Half of our workforce is underutilized. This is a failure of policy, not history. And as I stand here, I feel very proud about the fact that for 32 years I've been associated with Symbiosis, which is committed to both education and health. And if you see around, you'll find a lot of empowered women also. The Public Health Planning Advisor, Dr. Satish Kumar of the National Health System Resource Center, expressed optimism about the Universal Health Coverage Program, which he believes will motivate people to stay healthy, and he felt that at some point of time, this can be promoted by the National Health Assurance Mission, which can act as the best vehicle to take things forward. We need effective decentralization of healthcare systems as one of the strategies that need to be strengthened in due course. The future of NHAM, I'm sure, sir, you would be touching upon it in your talk, which will provide free drugs, diagnostic services, and insurance for serious ailments for nearly 1.3 billion people. And how this is going to unfurl, I'm sure Satish ji is going to speak about it in his particular session. Through his talk on the topic MDGs to SDGs, roadmap, map, and policy direction, he will share with us the strategies, policy imperatives to help us achieve some of the crucial indicators and targets. This was with respect to what, we have one of our panelists, Satish ji, speaking on. Academic literature tells us how nearly 80% of medical care costs in India have to be paid by the patient in terms of out-of-pocket, of which 70% of the expenditure is on medicines. This is also a cause of immerserization of poverty. While out-of-pocket expenditure for the world stands at 18.2% in 2014, China at 32%, France at 6.3%, India has a whopping 62.4% in this regard. Denial of essential life-saving medicines due to the lack of affordability and indebtedness is a harsh reality. A distorted market cannot and should not be the basis of drug pricing and policy, especially when the sale of price has no bearing with the cost of production and purchasing power of our people. I unquote the words of Dr. Meera Shiva of the All India Drug Action Network. She will be sharing with us various dimensions of this in her talk. The advisor at Niti Aayog, Dr. Alok Kumar, in his article in 2016 in the Times of India has written that the funds flow with respect to public expenditure has not really decreased. Rather, the pattern of its devolution has been modified for greater autonomy to the states, which has been an outcome of the 14th Commission, Finance Commission, which has taken the devolution of the funds from the center to the state, which was initially at 32% to 42%. This, he believes, will result in greater efficiency at the state and at the grassroots level and better outcome in the health sector. Dr. Ashok Dayal Chand, known for his work with women, child and health, and founder director of the Institute of Health Management, has been working in the area with married adolescent girls since 2003 to delay first birth, which thus addresses the burden of morbidity, which is a consequence of early motherhood. Since 2013, his institute has adopted an integrated approach and is working in this direction, and the institution has been invited by the government to scale up its adolescent reproductive and sexual health model through the formal health infrastructure. Well, when we are talking about health infrastructure, the industry has been demanding that it gets this status since 2012, and in 2017, the highlight has been shifted to giving it priority sector. Those of us from economics and the banking sector understand what we mean by priority sector out here. The optimism about community-based monitoring component has been absolutely propagated and supported by Nitin Jadhav and Sathi that he works with. This approach was introduced in Maharashtra in April 2007, wherein for the first time in the history of healthcare in independent India, the government has allowed such a process to take place in 9 states in the country. This has resulted in problem solving at the community level. He believes in the efficacy of the right-based approach over the service-based approach through structured Jan Sunwai or public hearings. Dr. Ashok Ji and Dr. Nitin Ji will throw light on civil society organizations and their role. And thus, my dear friends, we look forward to health in all policies. And as an economist, I would like to say, it is the business of economists not to tell us what to do, but show why what we are doing anyway is in accord with the principles and the proper principles. To invite our chairperson, Dr. Srinath Reddy, President, Public Health Foundation of India. May we have his profile up? May I now call upon you, sir, to share your views. A warm welcome again to everyone, and thank you.
Good morning. It's indeed a privilege to be here at the Symbiosis University, which represents the quintessence of global solidarity. I'm grateful for this opportunity that's been provided to me to speak at this conference, which truly reflects how best transdisciplinary learning can translate into multi-sectoral action for greater societal good. My role as the initial speaker that was assigned to me was to provide an overview of the speakers to follow and knit together some of the key elements of the topics that they would be addressing. Since Dr. Jyoti Chandiramani has already done a remarkably great job of that, much of what I will say perhaps will be superfluous. But the role, therefore, is that of a sutradhar who will try and bring together some of the elements of the various topics that have been very well selected for eminent speakers to follow. But I'll also act a bit as the provocateur in challenging some of the issues that are likely to be addressed later on and pose some questions which I hope they will take up during their presentations. We are meeting at a very important time in India's history in terms of health. Not only have we signed up to the Sustainable Development Goals in 2015, and they become operational since 2016. But we have recently seen the release of the National Health Policy document of 2017. We have seen the vision document, which actually charts out our developmental plan for the next 15 years up to 2032, but with a 3-year action plan very clearly delineating what the steps are which will realize some of the aspirations of the national health policy. So it is in that context that we need to consider the whole area of health financing and health economics and the economic planning for health, but in the context of what we hope to achieve in the overall health arena for this country. Indeed, when we look at the Sustainable Development Goals as the starting point, we recognize that there has been a marked departure from the Millennium Development Goals of year 2000, which, while well-intended and somewhat sharply focused on what were perceived to be major public health priorities of the poor, were directed only at low and middle income countries, were not truly global in nature. They fragmented by disease or health condition and segmented by age, and did not really adopt a life course approach, leaving aside many important diseases, whether it's non-communicable diseases or many important age groups, like, for example, the adolescents and the elderly. They also focused almost exclusively on mortality, not on morbidity, and they only looked at disaggregated indicators for tracking progress and did not really look at the equity indicators, which sometimes aggregate indicators mask within countries. So the SDGs have actually been a very welcome departure from that, having adopted a life course approach, and the very health goal, number 3, is quite ambitious and audacious indeed when it asks for healthy lives for all and health at all ages. So we are really looking at a much broader agenda in which now not only non-communicable diseases, mental health and injuries have been accommodated, but very importantly, a health system perspective has been brought in through an emphasis on universal health coverage and calling in target 3.8 for achievement of universal health coverage by 2030, including financial protection as well as access to essential medicines and technologies. Now, is there a need for greater investment? Clearly, with such a broad agenda, there indeed would be. But then the economists would always ask that what will be the returns on investment? We have seen ever since the Macroeconomics Commission or even the Commission on Investing in Health of 2013, which recapitulated but certainly advanced in terms of discussion the World Bank report of 1993 of investing in health, that indeed investments in health actually lead to substantial returns of economic growth for the countries. And the Commission on Investing in Health in 2013, of which I too was a member, indicated that the returns on investment would be 9 times. That means for every dollar spent, there would be $9 return for low-income countries and 20 times for the low middle-income countries like India. While this is indeed very encouraging, the problem is this modeling is being done for returns that would gradually accrue up to 2035. And very few policymakers would have the patience to wait till then when they're making their current decisions. So that is one of the problems. Also, there are countervailing forces which are likely to impede greater allocation to health as an economic investment. Firstly, there has been a sagging global economy, somewhat in a stage of recovery, but with multiple bailouts, the threats of wars, conflicts, migration, the appetite for investment in health, particularly in terms of global partnerships, is certainly lower. So we do need to depend a lot more on national resources. At the same time, at the global level, even at the political level, there is a political retreat from global solidarity with ultranationalism and protectionism raising their ugly heads. So it is in that context that we have to look at health financing and economics right now, and not in isolation. Universal health coverage is now a mandate of the SDGs, as I said. In 2012 at the World Health Assembly, Margaret Chan declared that universal health coverage is the most powerful concept that public health has to offer. And the next year, in 2013, the World Bank president said, Jim Kim said, we must be the generation that delivers universal health coverage. So the economists and the public health leaders, in terms of their leadership, have actually agreed upon this prime need. So we do have goal number 3 spelling out in target 3.8 that universal health coverage is needed. But what is universal health coverage? The WHO defines universal health coverage is when all people receive the quality health services they need without suffering financial hardship. And the WHO very helpfully portrays this in a cube which has 3 dimensions. First is the population which is covered, which is population coverage. The second is services which are covered. What is the range of services provided? And third is financial protection, that is cost coverage. What do people have to pay out of pocket? Now we recognize that the whole cube is not going to be filled in with all the people receiving all the services without any cost to their pocket, but we do have to progressively move in that direction, at least as much as possible. Now, there's a problem here. Politicians would be much more focused on population coverage. They would like as many people to be covered as possible, even if the actual services provided are thin, because the greater the number of voters satisfied, the greater the number of beneficiaries, the better it is from the point of view of their popularity. Of course, equity comes in. You want many more people to benefit. The health professionals would want many more services to be covered. They say our patients deserve the best, the maximum number of diagnostic tests, the maximum number of interventions, the maximum number of drugs. So they insist on service coverage. Economists and policymakers and civil servants managing systems are much more bothered about the cost coverage from 2 points of view. They want to reduce out-of-pocket expenditure so that the impact on induced poverty because of healthcare expenditure can be reduced. At the same time, they want any such investments to be fiscally prudent so that you don't bust the budget. Now, in this dynamic tension between these 3, how do we actually progress towards universal health coverage in steps? And that is the challenge that we need to consider. So there's clearly a need for increased health financing if you want to actually provide some elements of universal health coverage to begin with and upscale them later on. But there is also, and especially public financing, and we'll come to that. But also we need improved allocative and utilization efficiencies. How do we use the money much better in terms of choosing our priorities, and how do we bring in efficiency of delivery so that we get the maximum value for money? But one of the critical elements of universal health coverage, which is absolutely vital to its success, is the principle of cross-subsidization. Now, if you have universal health coverage, you need to construct a large risk pool in which the healthy subsidize the sick. Now, at any given time, there are only few people in a population who are sick. The majority are healthy. So when the sick have costs, what is contributed even in small amounts by the healthy in the risk pool will help to cover that. Now, I may be healthy today, I may be sick tomorrow, I may be sick today, I may be healthy tomorrow, but any given time the healthy must subsidize the sick. The rich must subsidize the poor. That usually happens in a progressive tax system, which is the basis for public financing of health. The young must subsidize the elderly because they're generally healthy and they're also earning. The elderly may not be earning, they may be more sick. So, social solidarity within societies is absolutely critical for the success of universal health coverage. It is not mere economics. Therefore, you need to create a large risk pool, and that best often happens, which is tax funded, but with a progressive taxation system, which automatically ensures that the rich will subsidize the poor, or a universal mandatory contributory health insurance where everybody pays from the payroll But with 90 to 93% of our workforce in the informal workforce, that is not likely to happen. But at least the government-funded social insurance programs must be pooled together to create one large risk pool rather than having them fragmented and scattered into multiple schemes. Now, coming to total health spending and governmental health spending, going back to 2012, though of course now the government spending has increased, and Dr. Alok Kumar will talk about that more later. But if you look at 2012, the data from WHO show that India's total health spending as a percentage of GDP was 3.8%, China 5.4%, Mexico 6.1%, UK with National Health Service was 9.3%, United States was 17%. Not now United States is close to 18-19%, but neither India nor United States were shining examples of how money should have been spent on health. But the real pointer to the distortion comes in when we look at the percentage of government spending on health. What is the level of public financing? In 2012, India's was 30.5%, whereas in China it was 56%, in UK it was 84% with the National Health Service. But surprise, surprise, even in the highly privatized United States health system, public financing was 47%. So it is the lack of public financing that has been really at the heart of our failing health system. But now there are remedial measures being taken, and that will be for the good. But one of the questions that has always been asked is, why can't we spend more on health in terms of public financing? That has something to do with our tax to GDP ratio. Now, the Scandinavian countries like Denmark have a tax to GDP ratio of 50.8%, Belgium 47.9%, France 47.9%, UK 39%, USA 26.9%, though Mr. Trump wants to slash it down to 15%. Fine. I mean, let's see where he goes. But even low-income countries and middle-income countries, Israel 36.8%, Brazil 34.4%, South Africa 26.9%, India 17.7%. Now, it is very unlikely that a government which wants to provide a market-friendly environment for foreign investment or even domestic investment is going to raise the tax rates and have a higher tax to GDP ratio. So, how are we going to actually bring in greater degree of public financing, and what happens to health care if we don't? Well, the governments over the last decade or even more have tried to address some of this problem through social insurance programs like the Rashtriya Swasthya Bima Yojana and a slew of state health programs like Arogyasri and so on and so forth. But the Brookings report, which looks at NSSO of 2004 and NSSO of 2014, I mean, some of my other colleagues also had published similar results, but this is a very consolidated analysis, says impoverishment caused due to poor health has remained unchanged over the 10 years. Overall, the percentage of Indian households that fell below the poverty line due to out-of-pocket health expenditures has remained unchanged at approximately 7% of the population. So 7% of the population are pushed into poverty because of unaffordable healthcare expenditure. Remained unchanged from 2004 to 2014 in percentage terms. But because our population has increased, the absolute number of people pushed into poverty has increased. It also says overall the different regression analyses show that having public health insurance coverage in India has not been associated with lower health burden as measured by 3 indicators: total real out-of-pocket expenditure, probability of catastrophic health expenditures, or impoverishment caused by health expenditures. So we have a major problem because our social insurance programs have not served the purpose of financial protection. They might have increased access to health care in some areas. Then comes the question of how do we handle this? The latest 3-year action plan, which Dr. Alok Kumar will be speaking more about, which has been released by the Niti Aayog, says the poor should be subsidized, but the non-poor should have mandatory co-payment mechanism. Now, the problem about co-payment is, certainly we may say, okay, those who can afford to pay must pay, but who are those who can afford to pay? What about the near poor, those who are just above the poverty line? If 7% are being pushed into poverty because their healthcare expenditure has been high, so the non-poor are vulnerable as well. There's a large section of the middle class which is vulnerable. So how do you build in financial protection for them? That means everybody who is non-poor, from the lower middle class to the richest industrialist, is going to pay the same amount of copay? Or is there a staggered, scaled up system? In a progressive tax system, you have that. But how are you going to manage in this system? So we'd like to hear some answers on that. What about the near poor? Basically, this is an issue that we need to look at. Now, in public financing for health, how do we actually increase the funds if we are not going to be really increasing the tax to GDP ratio? Hopefully, we do increase the tax to GDP ratio. But we need to strengthen the overall tax system. We need to curb tax evasion, especially by corporates, less of the Kingfisher route. And we also need to look at innovations like the Tobin tax, a transaction tax. In an overheated financial market, you might actually take advantage of that by having a transaction tax like has been proposed in France. Then frequently we have talked about sin taxes on tobacco, alcohol, junk foods, and luxury vehicles. Now, the problem is, even if you impose, and it's good to impose because that will reduce consumption, especially among those who have low disposable incomes who are vulnerable. Now, finance ministers don't usually earmark taxes. So even if you have these taxes, it will go into the general revenue. But expansion of the general revenue pool may permit the finance ministers to allocate more for health from the general budget. But it could be a perverse incentive. Because if you say, I'm going to depend on tobacco tax for my healthcare financing, the health ministry says, oh my God, my budget is mostly dependent upon the money from tobacco revenue, so the non-tax measures, I'll go slow on them. So it can only be an early or intermediate measure, it can't be a permanent measure. But Philippines has done well. It has raised taxes. 85% of the increased revenue from the increased tobacco tax is being allocated to health. 80% of that is being allocated to universal health coverage and 20% to infrastructure strengthening. Why can't we do that? Now, we also need to improve our allocative and utilization efficiency. So how do we allocate? How do we prioritize? So we need an essential health package. We have to begin somewhere with a core set of services. And I'm delighted that both the National Health Policy and the Vision Document and the Action Plan of Niti Aayog are actually spelling it out. But there's a difference. In richer countries, it is mostly a list of what is excluded. Because we are starting with low public financing, we have to start with a list of what is included. And we'll have to include essential primary, secondary, and limited tertiary levels of care. And the choices of this essential health package cannot be only on the basis of burden of disease or only on the basis of cost effectiveness. Epidemiologists and economists are not the only people to decide this. You require individual and societal burden of disease, mortality, morbidity, DALYs, size of health impact on disease burden, cost effectiveness, which is comparative, and generalized or incremental cost effectiveness analysis, degree of financial risk protection, how much of out-of-pocket expenditure does it decrease and how much of catastrophic health expenditure does it decrease, affordability, what is the fiscal space, what is the total budgetary impact, equity, is there attention to vulnerable groups, feasibility, what are the technical and legal restraints, how multisectoral has the action to be, health system readiness, you may have the most cost-effective intervention, but if your health system is not ready to receive and implement it, you are in trouble. Is the health system adequately resourced, responsive? Are there implementation constraints? What is the scope? Is the program scalable and sustainable? And finally, acceptability. What are the political issues? What is the alignment among stakeholders? What is the public acceptance? But with all of these, you need to construct an essential health package. And the most important element of this has to be primary health care. Basically, if you focus on primary health care, you will be able to actually tackle 80% of the problems, even up to 90%, and prevent the overload of secondary and tertiary care. and primary healthcare must act as a gatekeeper. So we need to start with a full range of primary services, a wide range of maternal and child health services, and include others as well, including essential drugs and diagnostics and essential surgical services. Don't forget that. That is often forgotten. We need to revitalize primary health services by using predominantly technology-enabled non-physician healthcare providers, strengthen from the sub-center but go up to the district hospital for linking up with secondary healthcare, and enhance community participation and monitoring. But a few words on purchasing. Now, there is a lot of talk about strategic purchasing, which is good. National health policy talks about it, the action plan talks about it. But at what levels? When we are talking about integrated comprehensive care, should we fragment care even in terms of purchasing? Because now the policy document talks about capitation fee model for primary care. Capitation means you pay a fixed amount per individual or per household for a year, and all services will have to be covered under that. And the theoretical argument, which has been shown in Kaiser Permanente to be fairly true, is that there is an incentive for the provider, who is thus paid, to focus on health promotion, disease prevention, early care, because you prevent later complications and costly secondary and tertiary care. Therefore, it is a financial incentive to do better primary care. But what has been proposed is that you have capitation fee model for primary care, but fee for service model for secondary and tertiary care. So you're breaking the link. You're breaking the incentive even for the primary care provider to provide comprehensive care, because if I'm a primary care provider and I'm only being paid for primary care through a capitation system, I'll refer every alternate patient to secondary and tertiary care and save my money. So it's a perverse incentive that's being created, and this has to be also worked out. Now, public versus private competition. Strategic purchasing is supposed to encourage competition between private and public sector, and both will be paid. Excellent, but is there a level playing field? Is the public sector sufficiently strengthened to compete with the private sector? As it is, and even if the government puts in a little more money now, the private sector can borrow money from the banks to buy new equipment. Will the government permit the private and public sector hospitals to borrow money from the banks at low rates to buy new equipment? Are they going to give them that degree of autonomy? So where is the level playing field? That has to be determined. And we must have a single payer system that avoids fragmentation and aids strategic purchasing of services. And for human resources, again, we need to focus on technology-enabled healthcare providers as well as increasing the number of healthcare providers at all levels, and that's where public financing becomes necessary. Just a couple of words on access to drugs, because that's important. There's a UN high-level panel on access to medicines which released its report in September 2016. I would urge everybody to read it. It says, members of the World Trade Organization should commit themselves at the highest level to respect the letter and spirit of the Doha Declaration on TRIPS and public health, refraining from any action that will limit their implementation and use in order to promote access to health technologies. It advocates the full use of TRIPS flexibilities and TRIPS plus provisions. It calls upon the members of the WTO to amend laws to curtail evergreening, report political or economic pressures by any country or company, adopt and implement laws that facilitate issuance of compulsory licenses. Essentially remove the roadblocks for compulsory licenses. And it also says the members of the WTO must now act together to revise paragraph 6 of the Doha Declaration to enable swift and expedient export of pharmaceutical products produced under compulsory licensing. So unless we ensure that, because drugs contribute to a huge component of out-of-pocket expenditure and healthcare related burdens, we will not be able to tackle the problem. So it's not just amount of financing, you need to tackle access to medicines. Fortunately, we now have emphasis on generics, price control, and pooled procurement. Pooled public procurement actually is a very important element to reduce the price of drugs. But the 3-year action plan disconnects the price control from the national list of essential medicines. The drug price control order is to be delinked. So what consequences that will have, again, we'd like to hear from Mr. Alok Kumar. Of course, stewardship and governance in various levels is required, a lot of regulation is required, but this is where the role of civil society comes in. Civil society is essential for priority setting, which is policy shaping, even if they're not policy making, for program support through participation in implementation, through monitoring and accountability as a watchdog, and also in participatory research. So again, the civil society becomes an important partner. So what we recognize is we do require mandatory coverage for all groups, contributions from those who can afford them, but even the near poor must be covered, and decrease in the number of pools and schemes in the country to increase risk pooling and efficiency, concentration on a comprehensive benefit package for all people and in all schemes, increased allocation for public health services, reliance on strategic purchasing, but with clearly regulated mechanisms, with clearly defined deliverables and mechanisms of accountability, and provide portability all across the country. Thank you.
Thank you so much for giving a wonderful overview and being the perfect Sutradhar. I now call upon Dr. Satish Kumar, Advisor Public Health and Planning, to come and deliver his talk. Like Soumya Swaminath, he's also made a very special effort to come here today. He also has a 2 o'clock appointment, and therefore we juggled it and put him, in the order up. Sir, please come up.
At the very outset, let me, on behalf of the National Health System Resource Center, express my thanks and gratitude to the organizers of this international conference, Symbiosis International University, for giving me an opportunity to share my thoughts with this august gathering on a subject which is extremely relevant and thought-provoking. My job has become much easier after listening to Professor Srinath Reddy. But let me begin by saying that today we find this world experiencing two mutually contradicting phenomena. On one hand, we find countries in many parts of the world torn apart by war, violence, internal strife, economic exploitation, and disparity. But on the other hand, we find heads of the many states talking about development goals, asking their nations and people for wider global commitments to eradicate hunger, disease, disparity, and usher in peace and prosperity. Now, this is something which is very reassuring, and maybe it really reaffirms the hope that ultimately it is the good which is going to prevail, and we have some brighter future for our children. At the same time, we will discuss as the discussion progresses that this whole experiences of implementing MDGs and now an attempt to migrate from MDGs to SDGs brings to surface certain fundamentals of public health, which really is very, very thought-provoking, at least to me as a student of public health, and I would like to express before this August gathering. The first is that the stable health status or achieving optimum level of health is not only dependent on initiatives in the health sector, but requires a very sincere effort to address wider social determinants of health. I mean, this is one thing which has been made very clear after we listened to Dr. Reddy, or after we have gone through various successful or not so successful initiatives to implement various, say, programs which were designed to reach goals, whether it is MDG goals or sustainable development goals. So that's one thing, wider determinants of health. Then it becomes more and more important as the country faces epidemiological and demographic transition. That's one thing. Second, of course, is that the sustainable development has to be locally owned. Whether you talk of resources or you talk of implementation.